the California Quality Improvement Coordinators Conference, the California Department of Public Health, the University of California, San Francisco, San Diego State University, and Zuckerberg San Francisco General Hospital. Please join me in welcoming Shaina to the stage.
Good morning. My initiative today is to talk with you. How's that? Great. My initiative, is to talk about our local perspectives on the opioid crisis. I'm going to do this in 4 primary parts. We're going to take a look at the community history of the epidemic, so look at some data and statistics about how we have been locally impacted. We're going to talk about a local organized response, so what it is that our agencies, providers, and small government officials have done to intervene in our county systems to address this issue. I'm going to talk a bit about a contemporary culture of recovery. What are the underpinnings of the work that we're doing philosophically? I'm going to talk a bit about parental and community approaches, so what individuals can do in their day-to-day lives as they're facing these issues. I'm going to do this all in less than 45 minutes, and I'm going to do it after you've heard several hours of engaging material and before you've been fed. So, here we go. I'm going to start with the tough stuff, which is some data on opioid poisoning fatalities. And I'm deliberate in my language here that I'm not using the word overdose. That's not an accident. Much of the work that we're doing is about breaking stigmas, because you know that stigma is a barrier for folks to access care. And so if we're deliberate in our language, we can help that initiative. So we're looking at the blue line in prescription opioids, and we're looking at a black line inclusive of all opioids per 100,000 residents in our community. We see some peaks and some valleys, but overall we are in a better place than we were, riding out some of those spikes that you see in 2011 as well as 2014. Here is a heat map that looks at our specific community areas from 2010 to 2017. We definitely have some hotspots. We've seen a little bit of cooling in those areas, but it gives us important information on where we can concentrate our efforts because these folks have been more impacted. Because we are talking about youth today, I think it's important to take a look at age specific to our community, and we see some anomalies as related to national data here. So our darker blue lines are looking at 2008 data, and then those greener lines are looking at 2017. In 2008, we saw some highest numbers in the older adult population, so we see 70 to 74, as well as those folks in the 50 to 54 age range were the most impacted in our community. And through 2017, we see higher numbers in the 30 to 34 range, followed by the 35 to 39. We do have some youth impact, but it's a little bit lower than other demographics. We have a lot of prescription opioids in our community. In 2016, there are approximately 188,000 prescriptions throughout our county. That's enough medication to medicate every single adult and child continuously for a 6-week period. In 2017, we saw some reduction of this number, a little under 163,000. So there's a duality here, because while we have a lot of prescription medication floating around our community, and we know that based on community surveys, that most people don't keep these locked up in their homes. Most people have them in their medicine cabinet, and we know that most people don't dispose of them properly, so we know that they're out there. However, we have seen a decrease in opioid prescriptions. So if we're looking at comparative data from 2010 to 2017, It's fair to say that in looking at that blue line representing Santa Cruz County as compared to the black line representing the state of California, that Santa Cruz was disproportionately impacted by this flood of opioid prescriptions. We had a lot more than the general population of the state of California. It's also fair to say that we've made some great proportional progress because we see that decline. And we see that our numbers are just about in the area of the general California population. And as we get our 2018 data, we're hoping to see that we are maybe even a little bit below that. It's important to keep in mind that California has had a lower impact as compared to the nation. National Institute reports say that there's about 4.9 fatalities per 100,000 people in California as compared to 13.3 nationally. So that's an important piece to keep in mind as we look at how we've been impacted locally. So let's take a glance at where these prescriptions are happening. So again, we look at our heat map as compared to between 2010 and 2017. And some of those hotspots are similar to the opioid poisoning fatalities map. I think it's important to talk for a moment about fentanyl, and we heard a little bit earlier today about the potency. So in 2016, in Santa Cruz, we had 2 fatalities as related to fentanyl. And the county issued a public health advisory, but that attention faded off a bit because we didn't see a continual spike. However, if you take a look at this map in relation to the communities around us, just in January of 2019 in Fresno, there was a fatality and 2 hospitalizations. Those folks thought that they were ingesting cocaine. However, they were ingesting fentanyl. We look at Chico, there was 12 hospitalizations and 1 fatality related to fentanyl. And in Oroville and Palermo, we've had 3 hospitalizations and 3 indictments for fentanyl distribution just in the month of January 2019 alone. So I think it's important that we be mindful that fentanyl can impact our community and that we may see an increase. And that, as mentioned earlier, we're seeing fentanyl mixed in with other drugs. We're also seeing fentanyl pressed into pills so that they mimic the appearance of pharmaceuticals. People think that they're buying a pharmaceutical or getting a pharmaceutical from someone, and they're actually getting pressed fentanyl. So when we look at our local organized response, now that we have a better understanding of what it looks like in our community, we can turn to how the organizations around us have responded to yield some pretty significant improvements. So I'm going to provide very brief overviews of what are complex and multi-layered programs and systems. Some of them you'll hear more about today, and I also want to just add that I make myself available to you all if you would like more information on any of these aspects. In April of 2013, the county launched the syringe service program. So that includes an advisory group, as well as needle exchange and education and treatment referral. In 2014, that added Narcan distribution. Or Narcan, as we've talked about earlier, can help prevent accidental fatalities because it's an opiate agonist and binds to those receptors, so it essentially blocks the drug from being active. And so we have a couple of statistics up here about through March 2015 to 2017, who those folks have served. And I want to recognize that syringe services can be a politically delicate topic in our community. However, what I want to bring your attention to is the bottom number, which is 64% of people that went into that needle exchange program in this period were provided with health education and referrals to care. So what it does is it allows people to build trusting relationships with healthcare providers, and 64% of them at some point or another, when asked, would you like some more information? Would you like some help? Said yes. We're fortunate in our community to have community prevention partners, and this is a collaborative with a lot of stakeholders at the table. We've got some county support, we have the Health Improvement Partnership, SafeRx, United Way, we've got schools, we've got police support, we've got hospital support. And you're going to hear more about SafeRx in particular later today. Some of the achievements that I wanted to highlight for you that Community Prevention Partners has brought to us is the work towards elimination of long-term prescriptions in the ERs. So making sure that when folks come in with acute issues, that rather being given large quantities of opioids, they're being given smaller doses with an emphasis on connection with their primary care physician to follow up and get to the root of whatever caused that emergency visit. CPP was really instrumental in helping to move the state forward to get the Cures database system up and running. So what Cures does is it allows pharmacists and prescribers to look up an individual and see what their history is of prescription opioids. So if they've been getting a large number, if they've seen another doctor and received a prescription, they have that information and can make an educated decision about what is being prescribed. We also, CPP has worked with the Alliance, which is our medical plan, to include alternative therapies such as acupuncture, so that we have this available as a resource for folks in chronic pain. And then the institution of safe prescribing practices, a lot of that's done one-on-one with physicians and medical directors countywide to help reduce that number of prescriptions that are issued, and as we've seen in our data, that has been successful. The other thing that we're pretty proud of is that every day in Santa Cruz is Take Back Day, that we have opportunities to turn in medications at pharmacies, at police stations. There's a number of opportunities within our community, so we're making it as easy as possible for people to safely dispose of those unwanted, unused medications. We have the Central Coast Recovery Options through Janus of Santa Cruz. They launched in 2017, and we're going to hear a bit more about them later. But essentially, they're utilizing a hub and spoke model where hubs are specialized licensed narcotic treatment programs, and spokes are healthcare settings embedded within the community where X-waivered providers are available. So those X-waivered folks are the folks that can prescribe buprenorphine. And referrals are bidirectional. So that if folks need more support at a spoke, they can get referred to the hub, and as their symptoms decrease at the hub, they can transition to a community spoke. Within the county health services, what we know is that a lot of times folks are not knocking on the doors of specialty treatment providers, but they're knocking on the doors of their doctor and saying, I need help. It's a little less stigmatizing. And so through county health services, we want to make sure that our staff are prepared to address that. In September through December 2018, there were 124 patients who received medication assistance for opioid use disorder through that contact with their physician at the county. And there are 10 active X-waiver providers. So they're able to provide Suboxone, and that team consists of physicians, physician's assistants, certified nurse practitioners, all working towards more comprehensive care and linkage to specialty referrals if needed for those individuals. I think it bears repeating that we have also joined in other California counties with a legislative response. In 2018, the county filed lawsuit against big name pharmaceuticals. Here's a list of some of the accusations: negligence, racketeering, false advertising. So we are taking initiative to look at all of the folks that are responsible and ask for their fair share in contribution to solve this problem. One of the things that we've really been focused on in the last 18 months or so is a full revisioning of how we allocate resources to substance use disorder treatment. And we've accomplished that in part through the Drug Medi-Cal Organized Delivery System. This is a statewide waiver that California engaged in with the federal government. It runs through the year 2020. And what it does is it allows us to utilize Medi-Cal dollars more broadly when we're treating substance use disorder. This is the first of its kind nationally, and so there's a lot of attention on the state of California and how we're executing this. We're piloting for the nation. Santa Cruz was one of the first counties to submit an implementation plan. This was voluntary, so each county could opt in or opt out of this system, and there are certainly benefits and risks associated. But the County of Santa Cruz made the decision to opt in because we really wanted to maximize those benefits, understanding that we have people who are Medi-Cal eligible in our community who are not able to get the care that they needed. So we went in and we went live with our services January 1st of 2018. The Drug Medi-Cal Organized Delivery System, or DMC-ODS, is built on a 6-dimension assessment. So when we're determining how it is that we can best meet people's needs, we're looking at these 6 areas of life as they interact with each other to determine their level of acuity so that we can place them at the right level of care. We've created a continuum of care. It starts with prevention and early intervention, moves into outpatient and intensive outpatient services. These are similar modalities, but they differ in dosage. So when we're talking about young folks, we're talking about outpatient services being less than 6 hours of treatment a week, and intensive outpatient being higher than 6 hours on an outpatient basis. And for adults, it's a little bit higher, it's 9. And then we scale into our residential services, both high intensity and low intensity. We also have withdrawal management services, formerly referred to as detox. Now, what you'll notice about our residential services is that there's a pretty significant shift and a revisioning of how we utilize those residential services. Historically, if we had somebody who was presenting as struggling with substance use disorder, even if it was mild to moderate and they had some life stressors, we might automatically route them to a residential program without really doing an assessment of what their needs are. So this gives us the opportunity to utilize residential as acute stabilization, and once that person is stabilized, we're able to transition them through the continuum to a lower level of care. When we launched our ODS system, our objective was really bringing more people into care at the right levels and then working towards seamless transition on demand between those levels. We had a lot of interest. So this is a sample of incoming phone calls to our community-based providers. And as you can see, November and December 2017, it was sort of business as usual. And mid-January, people started to hear that there were beds available, that there was funding available, that there were new treatment opportunities, and we saw a skyrocket in those requests. Even as those calls stabilized and people started to integrate into treatment, they leveled out at roughly double the amount of phone calls and requests that they were before we went live with our organized delivery system. So there's a number of ways to look at treatment data. We can look at admissions, which is the number of distinct treatment episodes that are initiated in our community. We can also look at days of service. So how many services as measured by a day were rendered across the community. For residential, that would be 1 bed day. For outpatient, it would be that day of contact, whether that was a group, an individual service, or both. The number of days that someone was engaged. So I prepared both for you. When we look at our intensive outpatient admissions, outpatient being the upper blue line and intensive being the lower darker line, we can see that we've had some sort of ups and downs, but overall increase in access to admissions to outpatient and intensive outpatient services. As we move into residential, this is where it gets really exciting. So, as we went live with Drug Medi-Cal services, we saw a significant spike in those residential admissions. Lots more people coming in, lots more people successfully accessing care, and that's starting to stabilize. For withdrawal management, also a large increase in the number of people. Our objective has been to double the number of people who engage in services, and with these numbers, we're getting there. So looking at days of service, for outpatient and intensive outpatient services, again, for outpatient, that extreme arc of increase in services. In Q1 of 2017-18, there were about 800 people who, 800 days of service provided throughout our community. We look at Q4 of that same year, and we're at about 1,800 and change. Residential days of service, significant skyrocket, and we're continuing to move up. So lots more people are accessing those programs, near doubling the residential care services. Withdrawal management, continuously seeing more and more folks. I do want to acknowledge that withdrawal management is one continued area of growth for our community. I think that as our objective has been care on demand, making sure that when someone is ready to receive care, that they receive care in a timely manner, we've for the most part been successful in doing that, including residential services. But withdrawal management is a bigger need than we've been able to tackle, and that's something we continue to work on. A planned expansion that I want to highlight for the purpose of this conversation is regarding youth services. So we have planned expansion in 2019 for the addition of 175 youth slots for prevention and treatment. They're going to be throughout North and South County, and they're going to include minor consent. So what that means is that young people can access services primarily at their school sites without notifying their parents. So there's a number of reasons that youth may want to talk about drug and alcohol use without talking to their folks about it. And I understand that they may stir up some feelings for parents, but ultimately it's one step towards gaining transparency about what's going on with that child or adolescent. Before we look at some specific parental and community-based interventions, I want to talk about how recovery has shifted. There's been really great efforts over the last couple of years to shift how we as a system think about and enact service provision. There's 4 main categories. We have looked at variable treatment episode length. We are emphasizing self-identified goals. We have revisioned our relationship with criminal justice mandates, and we are working towards implementing universal harm reduction. For variable treatment episode length, we're moving away from prescribed length of duration. So rather than someone coming in and saying we're going to do a 90-day stay, a 30-day stay, a 28-day stay, what we focus on is that substance use disorder can be a lifelong issue, and that while we may see symptoms go into remission, we know that we don't have a cure. And so this continuum allows us to acknowledge progress and ensure that the system fits the individual's experience and can scale up and down as their presentation changes. We're emphasizing self-identified goals because we acknowledge that folks that use drugs, just like everybody else, have personal rights, and they have the right to take the initiative and determine what it is that's important to them and how we as service providers in their service can help them meet those goals. We have to acknowledge that that's not necessarily abstinence all the time, that we have folks that may want to ameliorate some problems associated with their use. They may want to reduce use. They may want to reduce use of one substance and maintain use of another substance. And by utilizing identified goals that they themselves have collaborated on, we let the person know that they're driving. They're in control of what it is that they want to achieve. And so we support them in that. We know that if we don't do that, then we either won't get folks to engage in treatment, or they won't be honest with their treatment providers. If they know that there's a judgment and an assumption that they need to be 100% abstinent, and that's not where they're at today, they're not going to tell us that if we don't create an environment where that is the reality. We've done a lot of work over the past year and a half to revision criminal justice mandates. So historically, within our community, when someone presented in the legal system with any kind of a substance use issue, they were mandated to residential care for a certain number of days. So what that did is it did route some folks who needed that level of care into treatment. It also routed a lot of folks who may not necessarily want or need that level of treatment into our residential programs, and then we had a backlog. We had significant wait lists. So what we've done is we worked really closely with the jail staff, with the bench, the judges in our community, to think about how do we help someone who's within the criminal justice system access the appropriate level of care. And that's where the ACM comes in, that we are shifting towards doing those assessments with folks while they're in custody to determine what's going to best meet their need, and work with the judges and work with the probation and parole to create a treatment opportunity for them at that appropriate level of care. And this has resulted in better care for those folks, but also an increase in community access to our limited number of residential beds. So let's talk about harm reduction. I put up this quote from the National Harm Reduction Coalition as a starting point for a definition. We know that harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. So for me, when I think about the opioid epidemic, when I think about the folks that are struggling in our community, harm reduction is the first and foremost thing that comes to my mind. I am a harm reductionist at heart. If you had gone and looked for me 13, 14 years ago, you would have found me in the Tenderloin district of San Francisco, sitting down on sidewalks, walking into shelters, talking with folks who were using opiates intravenously about what it is that they needed and how we could help them. And a lot of times what they needed had nothing to do with abstinence. But if we're able to meet that need, if we're truly able to treat people with dignity and respect universally, we're able to acknowledge what it is that they want out of their lives, sooner or later we arrive at that point that we're addressing the substance use. So we know that there are people in our community who are struggling with opiate and other substance use. We know that these folks have high incidences of struggling with trauma and other mental health issues. What we know about ACEs, adverse childhood experiences, is that not everybody who has substance use disorder, not everybody who experiences trauma develops a substance use disorder, but almost all of the folks that we're seeing with substance use disorder issues have experienced some kind of trauma. And harm reduction acknowledges that. We know that these are really complex issues that require specialized care and acute interventions to break down stigmas. We also know that criminalizing drug use has failed, that it is not effective to jail someone for their drug use. And I think that considering that in parallel with the way that we work with youth, for example, kicking somebody out of school for their substance use, probably not going to provide the support that they need. I wanted to show you just a few images from a photography project done by the Harm Reduction Coalition showing what harm reduction means to individuals. And some of the themes that we see coming up over and over are restoring dignity, never, ever, ever giving up on people, understanding that this is not a simple problem and it's not driven by willpower, but that we have an opportunity to try to help people save their own lives. So for a moment, let's think about a medically informed harm reduction approach to opioid use. So this is my doctor. Now let's say I go to my doctor and I get a checkup and my doctor says, I'm sorry to tell you, you have diabetes and it needs to be addressed. So here's what we're gonna do. I need you to leave my office. It's not appropriate for you to be here. I'm going to ask you to get on a strict diet regime. No more sugar, and you're gonna have to rely strictly on your willpower to go ahead and do that, because we've all had great success with that. You're gonna have to launch an intensive exercise routine every day. You're gonna have to white knuckle it. And you know, all of those people in your life, your full support system, the friends and family that have been there for you through all the tough things that you've been going through, you can't hang out with them if they eat cake. And once you figure out all of that and you get your blood sugar under control, come on back and we'll give you some medical care. So if that's what my doctor did, my doctor probably wouldn't be a doctor for very long. And we need to have a similar approach when we're looking at opiate use disorder. When we have folks come in seeking treatment, we want to determine what's a realistic goal for them. We want to set small, measurable steps towards that progress. We want to offer them medication and other supports, connect them with resources. We have to maintain non-judgment, and we have to make a plan for slips, because we know sooner or later we're all going to eat cake, right? This is the model that we're striving for. So how can community members, as parents, as involved, proactive citizens, intervene? One of the things that I was asked to do is provide an overview of when a young person is using opioids, what does that look like? So here's my slide for you. And as we look at it, and we look at things like anxiety, depression, irritability, increased sensitivity, changes in appetite or weight, changes in sexual urges, that sounds a lot to me like your typical teenager. And so I think that we need to rely more on relationships that we have with young people than just looking for these physiological signs and symptoms. We can do that through person-centered approaches. I may have expertise in working with folks who are struggling with substance use disorder. I might have letters behind my name or other things that qualify me to offer support and help to these young people, but I will never be an expert on their experience. Only they can do that. Each person can define and build their own path to healing and goal achievement, and I can't do that for them without that knowledge, so it needs to be a partnership if we're going to be successful. I can offer ideas, I can listen for cues, I can introduce tools, I can provide unconditional positive regard and any other number of interventions from an evidence-based menu. But if that person's not engaged and invested in those strategies, if they're not able to talk to me about what they know about themselves and how that's going to impact their use, then there's no amount of qualification that's going to give me the power to heal that person. So we need to build trust with young people. We need to collaborate, emphasize their strengths because we know they have a lot, and value their experience and their perspective as we move forward together. Person-centered approaches invite choices. They explore personal responsibility for outcomes, and we're following the lead of the individual. It's not, here's what you need to do to clean up your life. It's, how can I be helpful? What is it that you need that you're not getting? And how do we as a community rally the support around you to get there? And I want to be really specific that harm reduction approaches are not giving people permission to use drugs, right? Harm reduction means we know that people use drugs. So let's be realistic about it. Let's engage in those dialogues. And let's explore personal responsibility. So what does it mean to make this choice? How does this impact your life? And do all of these actions and all of these behaviors and all these things that you're struggling with provide a consistent path to where you want to go? And if the answer is yes, then great. But if the answer is no, then how do we help you shift that? We need to create open dialogues, separating judgment from responses. So human beings are, by nature, judgmental creatures. You could argue that that's adaptive. You could argue that it makes our life harder. And there's a lot of therapists who spend a lot of time with people working on judgments. But at the end of the day, we still judge. And what's important when we're working with young folks is to separate that judgment from the way that we respond to them in the room. So if you need to yell or cry or fume or lose control of how you feel when you're working with a young person who's struggling with this issue, that's fine, but don't do it in front of them. When you present with them, be non-reactionary. Practice universal positive regard for that person's experience. You can talk to them honestly. You can say that, this is how things are impacting me, but we want to be really cautious about avoiding labels. So you can talk to them about honesty and the impact of being honest or not being honest. But when you call someone a liar, you put them in a box. And once they're in that box, it's really hard to come out of it. So we can talk honestly about what's hard or scary in regard to a person's substance use without ever calling them an addict. And we can explore disagreeing versus disapproving, right? Questioning the rationale behind a direction versus saying it's not okay for you to do this, it's not okay for you to be this. We can invite change. So stages of change it's the trans-theoretical model, and it very much informs how we proceed, because when we're having conversations with young folks about opioid and other drug use, we're gonna do different things for someone who is in pre-contemplation, meaning that they don't acknowledge that there's any kind of issue and they think things are going just fine, versus someone who's in preparation, someone who says, this is not working for me and I'm ready to make some changes. So if we utilize this cycle, we understand that different people in different places have different needs. We also acknowledge that there is a component of recycle, that folks who are striving for abstinence or striving for reduction in use may not be successful every single day, but that we acknowledge that every day that they're trying is a step forward, and that no slip or use is going to erase the progress that they've made. We celebrate the small accomplishments, the little things every day that that young person is working on to move forward towards a lifestyle that they identify as successful. I think it's important to practice pragmatism when we're working with young people, because this is really hard stuff. We don't have a cure, and there is no singular solution. It's a long path, it's hard work, and it's often nonlinear. We have to acknowledge that the prefrontal cortex, that part of the brain we talked about earlier that's responsible for rational decision making, is still developing in young people and doesn't finish developing till their mid-20s. And so it may feel like maybe they're not making a great choice. Maybe they're not able to make that great choice right now. So we need to acknowledge that when we're working with young people. I also want to strongly encourage people to lock up and dispose of your medications. If you have them in your house, and a lot of us do, lock them up. If you don't need them anymore, dispose of them. Bring them to the pharmacy, bring them to the police station, get rid of them so that we can take them out of circulation. I also strongly encourage folks to obtain and train on how to use Narcan. It's really simple. It can save someone's life. We have intravenous or injection as well as nasal kits, so it can be easy as inserting and puffing that up with someone's nose to reduce the likelihood that they're going to experience a fatal drug poisoning. So they're available, they're around. Even if you think you'll never ever need it, better to have it and not need it than need it and not have it. I thought a lot about how to close this talk, and there's a lot of very inspiring poetic words by a lot of scholars and researchers. But what I landed on was a quote by Mary Howe, who is a member of the Home with Youth Alliance. She was once a consumer and is now in a leadership position. And what she said is that before, we could always kind of do this othering. It's that kind of person, it's not me. But now it is me. Now every community can say, it's in my community. And I think that that's really appropriate for what we're looking at with opiate use in our community. When we choose to embrace our community members, all of them, not just the ones we decide are worthy based on income or job status or housing or lack thereof, but everyone. We see the value in all of those folks. We come to a place where we can acknowledge that some people need help and that it's our collective responsibility to do what we can and to hold hope for those who can't hold it themselves and to never, ever, ever give up. That's all I have today. Thank you.